Hello, I'm Jan Lathan.
And I am Muskan Joshi.
Welcome to MedNews Week Conference, where we feature presentations by medicine's global leaders. Today we have an amazing keynote speaker in Dr. Joseph Mikhael. Dr. Mikhael is the Chief Medical Officer of the International Myeloma Foundation. He's also a professor in applied cancer research and drug discovery at the Translational Genomics Research Institute, or TGen, of the City of Hope Cancer Center. He's also a consultant, hematologist, and director of the Myeloma Research Phase 1 program at Honor Health Research Institute.
In today's presentation, Dr. Mikhael discusses the most recent advancements in multiple myeloma and where its research is currently headed.
Did you know that Dr. Mikhael is the co-program director and principal investigator of the Phase 1/2 trial MLN 9708, Pomalidomide and Dexamethasone for relapsed or refractory multiple myeloma? He's also the leader of the first ever ASCO Guidelines for multiple myeloma and an internationally renowned and recognized educator.
A true global leader in the field of oncology.
So let's tune in and learn from this spectacular global leader.
As I've said, I've tried to break this up into three parts, into developments, disparities, and directions. So developments, what do I mean by that? What has really happened in myeloma over the last year? And I'm going to focus on three areas within those developments. A few large screening trials that have been done to help us understand the pre-myelomatous condition. I know some of you are very familiar with myeloma. Some of you don't know very much about myeloma, and that's okay. But myeloma, I could argue, is the most common cancer in the world, in the sense that 5% of the adult population, if we look for it, has a monoclonal protein in their blood, has some kind of pre-myelomatous condition. So trying to understand the pathophysiology and epidemiology of that is going to be critical to understanding the disease. And we've just seen two large screening trials done. I'll talk a little bit about how we're developing in frontline therapy as we move towards more intense treatments early on in myeloma. And then perhaps the area that brings the most excitement in what's developing in myeloma is really what's coming in our emerging therapies for late stage disease or triple class refractory. After patients have been treated with the three major classes of drugs, what do we do? And now we have tremendous options. But as was noted, I have a particular passion for health disparities. And so I think it's important to talk about disparities. And so we'll discuss the importance of these disparities. And as we know, they're prolific across almost every disease, but particularly important in multiple myeloma. And just the research that was presented over these last 6 months at ASH, I think is going to be important to highlight, perhaps more important, what we're doing about it. And I'll share with you some of the work that I'm committed to doing through the International Myeloma Foundation for that. And then lastly, look, I'm just Joe, but I'm going to be a prophet for a minute, and I'm going to give you Dr. Joe's 10 predictions for the future as we think of what direction we're going into. So there were two screening studies, as I mentioned. We think about some of these developments, what's called the iStop program and the PROMISE study. But as a background, before I tell you about these two studies, screening for cancer is becoming more important than ever. As we come to learn, detecting cancer early has a huge impact on what we can actually do for patients and improve their outcomes. It's better to catch early. I know there's a whole other area of prevention, but not even speaking of prevention, just being able to detect it earlier. But thus far, I've really not done that in myeloma because the pre-myeloma condition is so prevalent that it hasn't really justified screening everyone, because myeloma itself is quite rare. But we know that there are certain groups that are particularly high risk, especially in African Americans. So in the first study, which is arguably the largest screening study ever done, it definitely in myeloma, if not, some would argue even in malignancy, my good friend Sigurdur Christensen and his colleagues created the iStop program, or Iceland Screens, Treats or Prevents Multiple Myeloma. That's what iStop stands for, where they really literally wanted to screen the whole of the country with the tests that we do for multiple myeloma, with a serum protein electrophoresis from free light chains, although we also added a component of doing the serum testing through mass spec. And those patients that were determined to have MGUS, or the monoclonal gammopathy of undetermined significance, that pre-myelomatous condition, would then be randomized to three approaches, where we just don't do any further workup. We follow the classic guidelines of roughly once to twice a year following patients, or something more intensive, trying to see that if a more intensive screening program could lead to better outcomes, with a whole series of aims that I can't get into all of them, but understanding what is the overall impact, what is the best way to screen, how does screening impact quality of life, developing a huge biobank. One of the reasons Iceland was chosen is more people in Iceland have had their genome sequenced than any other country per capita. And so maybe there's a way to discover the drivers of this disease, genetically speaking. Obviously, I don't want to get too geeky on you with the genetic side of it, but it's a fascinating concept. So just over the span of those few years, as you see here, from November 16 to October 2018, they had over 80,000, I'm not lying here, 80,000 people agreed to participate. So 54% of the whole population. And since that time, the samples have already been collected in 93% of them. Now, Iceland has a very sophisticated, centralized healthcare system. So whenever someone accesses the system, if they've already given consent, then their blood can be drawn for that. And so you can imagine that there were patients detected, well, 28 of them had myeloma, but nearly 4,000 of them had MGUS, of which there were some that were previously known with MGUS. But still, about 3,500 patients still had newly diagnosed MGUS, and they were randomized to those three arms that I've mentioned, with a little over 1,100 in each of those arms. And by their follow-up, and again, it's still early to make final conclusions, but no surprise, those that didn't have much follow-up were rarely diagnosed as having an important disease such as either smoldering myeloma or active myeloma, green and blue here. But those patients that had the most intense follow-up had the highest amount. So in this really huge study, almost unbelievable number of patients, that they did, no shock, but importantly demonstrated that a more intense screening is going to discover a more active disease, not just the pre-myelomatous condition. Now, it's still not a license to go and screen people, but it's gaining evidence for us and accruing evidence for us that will really be important. So my commentary on this, even though my last name is Mikhael, a lot of people just call me Dr. Joe for simple. The sheer size of this study is staggering. There's a lot to learn. How common really is smoldering myeloma and not just MGUS? What happens if someone has MGUS but never develops myeloma? Do they have a different outcome in the long run in terms of survival or any other associations that may be there? Could we discover the genetic basis of this disease by virtue of what I said earlier with the whole genome sequencing that's been done in so many of these patients? And ultimately, the most important question is, should we be screening for myeloma for everybody or in high-risk populations? When we screen for other diseases like breast cancer with mammography or colon cancer with colonoscopy, we don't just screen everybody. Often there's gender or age-based guidance to do so. And would we be doing the same in myeloma? We don't know yet. The other large study that I think is important that was presented was the PROMISE study that I had a privilege of helping develop in the early days with Dr. Irene Gabriel from Dana-Farber, where they wanted to look at a similar kind of approach, but now selecting high-risk populations, those African Americans that identify as Black, and those people that have a family history of a hematologic malignancy. And again, I won't go through all the details, but the bottom line here is there's different ways of looking at the numbers, but clearly these individuals, if we think roughly 5% of all adults or patients over 40 have this, here that number is closer to 17%. And depending on how we look at other potentially pre-myelomatous conditions, that number could be higher, but that's still to be evaluated. But nonetheless, there's still clearly a much higher incidence of this condition in people who are first-degree relatives of those with heme malignancies, or indeed of patients who are Black. And so I think there's going to be discussion before time as to when we may have to start thinking of screening patients. Well, I mentioned in the developments, I talk about screening, frontline therapy, and relapse therapy. So what of frontline therapy? Well, for those of you who are very familiar with myeloma, we've for many years now been using a 3-drug combination, typically VRD or bortezomib, lenalidomide, and dexamethasone. Well, We now have a lot of data saying maybe it's better instead of 3 going to 4. Just like a few years back, we went from 2 to 3 and we found that a triplet was better than a doublet. Well, should we be using quadruplets? And probably the primary study that's influencing us right now is something called the Griffin study that Jacob Laubach presented at ASH, where, as you can see here in the 2 arms, patients were either given the quadruplet for their induction and for consolidation after a transplant, so these patients are transplant eligible, versus giving the standard approach, which is giving RVD then a transplant. We don't always use consolidation, but in this study, they opted to give 2 more cycles of consolidation, then followed by, interestingly, maintenance therapy. And the standard of care right now in maintenance therapy is lenalidomide alone, but again, following the same modality, they gave 2 years of daratumumab with the lenalidomide. So that's what the D is here, is if we add daratumumab to the classic bortezomib Lendex, and then wanted to obviously see the outcomes of the 2. And as you can tell in the purple arms, they had not only deeper responses, but with each layer there was deepening response, meaning after induction, after transplant, after consolidation, after 1 year of maintenance, after 2 year of maintenance. By that point, you have 82% of people who have reached greater than a complete remission, which is in contrast to 61%. So there's a good 20% absolute upgrade when adding the daratumumab to that 3-drug combination. We've also come to learn that it's not just about complete response rate. Really, probably the best measure is MRD negativity. And here you see almost a doubling of the MRD negativity from 44 to 81% with the quadruplet. A little bit early to make final conclusions about progression-free survival, but you can see a little bit of the splitting of the curves here to help guide this. Another 4-drug combination that was used was now adding daratumumab instead of adding it to bortezomib, lenalidomide, and dex, now adding it to carfilzomib. This study actually went a step further, and Luciano Costa, a good friend, I think was quite brilliant in his design here, where his design was not just to give the 4 drugs, the transplant, and more of the 4 drugs, but testing people on a regular basis for MRD negativity. And when they had MRD negativity twice, that their regimen could be stopped. Because one of the questions is, it's not just about giving, going from 3 drugs to 4 drugs, or maybe even someday, who knows, to 5 drugs. Do we have stopping rules? Because I can tell you, my favorite drug to give patients is nothing, right? Patients love when you can stop treatment, and do we really need to treat people forever? And so he wanted to ask that question in this study. It wasn't a massive study, but big enough to suggest. And the bottom line that he showed was that in patients with lower risk disease that either had no or maybe 1 high risk cytogenetic feature, this tact seemed to, generally speaking, work, that you could get people to a deep enough response that when you stopped, they stayed in remission. However, those people with the higher risk phenomenon, so-called ultra high risk disease, or sometimes called double hit, there's different definitions that I won't bore us with tonight, but those patients relapsed quickly. So those people, we can't take our foot off the gas. And then lastly, the only of these two studies I've mentioned, this is the 3rd one that is now actually a large phase 3 study. We're now, instead of using daratumumab, we're using a different CD30 antibody that I had the privilege of developing, the isatuximab, being a part of the development. The credit goes to so many. But the German group wanted to look at adding isatuximab to bortezomib, lenalidomide, and dexamethasone. And it's a bit earlier on, so we don't have the data after transplant or after the maintenance phase, but even just after those first 18 weeks of giving ISA plus RVD versus RVD, we see a dramatic difference in the primary outcome of this study, which I have to say is impressive to see for the first time, really the primary outcome of a study being MRD negativity. And as you can see, with just 18 weeks of therapy, half of patients got into MRD negativity when given the quadruplet, as opposed to about 35% in those patients that had the triplet. So it looks very much like adding a CD38 antibody, whether it's to BRD or KRD, is definitely feasible. We don't see a lot of incremental toxicity. We see an improvement in the depth of response, including MRD negativity, and a trend towards progressive-free survival improvement. It may be able to overcome high-risk features of some patients, but in that highest risk group, we still need something better than what we're currently using, which is a bit of a segue into what we're using later in relapse disease. So again, I don't want to give you a long basic science talk and bore you here, but it's always good to get back to a little bit of the biology of this disease. Why is it so important to treat this disease well up front? Because with time, this disease becomes more aggressive. It acquires new mutations. It becomes chemo-resistant. At the same time, sadly, the patient is getting older and is acquiring other comorbidities. And as you can see, with each relapse, the time in remission typically tends to get shorter. So it speaks to us about how important it is not only to catch the disease early, but to treat the disease well early on, because also pragmatically, with each line of therapy, there are fewer patients eligible for transplant. So we don't get into this habit of so-called saving the best for last. I've often joke saving the best for last is great for a Hallmark movie, but it's not true for multiple myeloma, as we need to be able to control this disease early on. So when we approach a patient with a relapsed disease, we don't have a simple algorithm. We don't just say, oh, I use this first, I use this second, I use this third. That doesn't happen anymore. We think of relapse disease as early and late, or 1 to 3 prior lines and later relapse, and ultimately, as I commented earlier, triple class refractory myeloma that I'll come to describe. But as we treat, and for the clinicians that are here tonight, 4 really important principles as we treat relapsed myeloma. Number 1, depth of response does matter. I've tried to show that even earlier in frontline therapy. We're not necessarily having MRD testing guiding our treatment right now, but it's clearly influencing prognosis and will likely influence treatment in the future. Myeloma is really not one disease. It's aptly called multiple myeloma because we have really quite a range of the disease, not just from what we said earlier of MGUS or smoldering myeloma and active myeloma, but even within active myeloma, a huge spread between the lowest risk and the highest risk disease. And we have to respect that. Some patients do require more aggressive therapy. We always have to balance efficacy and toxicity, right? We don't just say to patients, you'll take it, you'll like it, you'll ask for more. I mean, never, God forbid, we take that kind of approach. Should we ever take that approach? So that it's one thing to say, look, we got this treatment, it's going to make you sick for a little while and then we'll get you through it. But if you're giving people continuous long-term therapy, we have to balance that efficacy with toxicity. And then, of course, when possible, because of that biology that I showed you, where the disease acquires more mutations, becomes more aggressive, we want to change the mechanism of action when possible. So right now, the guidelines for myeloma, these aren't really guidelines, right? Because it's a huge list. I'm not going to go through this whole list, of course, but it's amazing how we see this sort of laundry list of opportunities and options, whether it's early relapse or later relapse. So we really have quite a remarkable list. So how do we choose? Well, a group of us from the International Myeloma Working Group wrote this paper last year where we tried to give some guidance based on whether or not patients are refractory or not refractory to lenalidomide. Typically, they are refractory in our purposes here because we use lenalidomide in maintenance therapy. So we can have preferred options and secondary options. And I'm not going to go through these much in early relapse because I don't think there's been as much that's developed here very recently, very much so in the last few years, because now we have literally 5 huge phase 3 trials to guide early relapse, of which I've listed 4 of them here: the Candor, the Ikema, the Apollo, and the Icaria study, and whether we're using the CD38 daratumumab, CD38 antibody daratumumab, or the CD38 antibody isatuximab, whether we combine it with either carfilzomib, listed here as K, or pomalidomide, listed here as P, we have great outcomes from each of these. In fact, we're just going to present new data from the Ikema with now over 3-year progression-free survival using isatuximab and carfilzomib in relapse disease. That being said, we now have to think about what happens after I use those treatments. What do I do when patients now become genuinely triple-class refractory? Of which there are several options that we can discuss here briefly. The first is selinexor. So selinexor was initially approved by itself, but now we can add bortezomib to it, and I'll tell you a little bit more about selinexor on the next slide. But it is really a novel mechanism of an XPO1 inhibitor that I find quite fascinating in the sense that this drug blocks the normal pathway that gets upregulated in cancer cells to get rid of those good tumor suppressors in the nucleus. So you want tumor suppressors in the nucleus. Keeping them in there keeps the cell in check. But when we get rid of those suppressors, the cell has a greater opportunity to become malignant and remain malignant. And so selinexor is the first of class of drug to be able to block that pathway, the exportin-1 or XPO1 pathway. When we gave it initially, I have to confess, it was tough to give. I've given a lot of it, hundreds of patients now, but giving it twice weekly, it was pretty tough on the GI system. But now we can combine it with drugs like bortezomib or even carfilzomib, and we can give it once weekly, and it's much more tolerable. Similarly, belantamab mafodotin is the first drug to target BCMA, or B-cell maturation antigen, which is heavily expressed in multiple myeloma cells. The challenge has been is it comes with some ocular or in particular corneal toxicity, and we're still optimally figuring out the dosing. That being said, it's a very effective agent, a single agent, over 30% response rate. And then really where the greatest excitement is right now, where we've seen so much new, is in the CAR T cell world. And I'm going to talk a little bit about what we're doing in CAR T cell therapy. The challenge is, of course, there's still an access issue. So as I mentioned with the selinexor, if you're a clinician here tonight, we've had a couple of publications over the last couple of years that you may want to look into, or to cure your insomnia. But if you want to look into, but a couple of things that don't dismiss the toxicity of this drug. It does require some intervention, supportive care, especially that first month. The first month is the worst month. And I try to highlight it here with 4 key points. Prevent the anorexia and nausea by giving 2 antiemetic agents, classically a 5-HT3 antagonist and olanzapine. 2, hydrate weekly for those first few weeks, because that's when people can get dehydrated and a little bit behind on their diet. Monitor their food intake. And if they start missing meals, then we need to intervene more aggressively and educate patients about those potential side effects. But you get them through that first month, it's amazing how much more the drug is usable. Now, when we talk about later relapse, as I said, we come to CAR T cell therapy. We have a tremendous opportunity here, of which I'm going to speak to in a moment, including more recently the CARTITUDE-1 study that led to the approval of our second CAR T cell therapy, cilta-cel. And also this whole notion of bispecifics, which I'll show some images and pictures of, but the bottom line is that we have now monoclonal antibodies that are dually built, one to hook onto the tumor, typically through BCMA, but now with other targets, as you can see here, like GPRC5D and FCRH5. And the other arm of the drug reaches out to a local T cell, or maybe even not T cells now, with things like NK cells that we can activate. I have a clinical trial going on looking at that right now, where we can engage that T cell or that natural killer cell immediately into the tumor to destroy it. So we don't go through all of the challenges of CAR T cell therapy, where you have to take T cells out and you manufacture them and you multiply them, and then you have to give patients lymphodepleting chemo and then you give them back. Not that that's not feasible or useful, because it has extraordinary response rate and generally manageable toxicities. But if we can avoid all that by going straight to a bispecific, it may be of value in certain patients. And we're seeing response rates that are really quite impressive. You know, those single agent drugs we've talked about typically have a response rate of 25 to 30%. We double that with bispecifics, and we triple that with CAR T cell therapy. And we'll talk a little bit more about that as we go. So what of this CARTITUDE-1 study that Tom Martin presented at ASH this year? So this is the classic CAR T cell trial, where, of course, we screen patients, we apheresis them to collect their T cells if they need bridging therapy in the interim, and then we manufacture the T cells off-site. And then we prepare them with some cyclophosphamide and fludarabine, give them the cilta-cel infusion, and typically we see response within that first month. The trick, of course, is soon after that infusion, people can experience cytokine release syndrome and other neurological toxicities. But even us as geeky hematologists, I mean, jaws are on the floor when this is presented, because, as I mentioned before, we've seen response rates 25 to 30% typically in heavily pretreated patients. We got an overall response rate here of 98%. So only 2 patients out of 97 that did not respond. And even then, there's some interesting things to learn from those 2 patients I don't have time to talk about tonight. But not only is the response rate staggering, the depth of that response rate, where 95% of them have a VGPR, a very good partial remission, which means a greater than 90% reduction in their tumor, and over 80% of them have a stringent complete remission, is genuinely unheard of. Furthermore, they're durable responses, where the 2-year progression-free survival hasn't been met yet. Over 2/3 of patients are still there. And indeed, overall survival where again, we're at 2 years and we're still seeing 3/4 of patients still surviving. So really a remarkable outcome that we've not historically seen before, as you see here with the overall response rate at 98%, and then the 2-year PFS of 60% and 74% with overall survival, with, as you saw, the MRD negativity and really a remarkable number of patients. So this now being added to our current CAR T-cell therapy of ide-cel has really added a great armamentarium for us. The biggest challenge, of course, is access, as you may have heard, whether it's supply chain issues with viral vector. There's a whole host of reasons why the majority of patients today eligible for CAR T-cell therapy simply cannot access it. But we hope that over the next several months will continue to improve. Part of the way we can overcome this, as I mentioned before, is through bispecific therapies. And so the first of which will likely be approved will be this drug teclistamab, which is a bispecific antibody, as you can see here, that targets the BCMA on the myeloma cell and the CD3 on the local T cell. And so again here, if you look at this picture where this bispecific therapy acts as kind of a bridge between the myeloma cell and the T cell, it sort of says, hey, how you doing? Introduces the T cell to this myeloma cell and activates the T cell so it can immediately destroy it. Try to obviate the need, as we've said before, of those collection of T cells from the patient and the manufacturing process in general. I'm just trying to give you the highlights here. Again, incredible response rate, 62%. So may not be at the level we've seen with CAR T, but not impressive nonetheless for monotherapy, where, as you can see here, about a quarter of patients achieve MRD negativity. Now, it does come with some risk. Of course, we see the usual cytopenias, so I don't want to make light of that. But also there is a risk of cytokine release syndrome. Thankfully, overwhelming majority is grade 1 and 2, which is quite manageable. If you're not familiar with cytokine release syndrome, this is something that happens after the drug is introduced, where various mechanisms are proposed as to how it happens, but it's quite an impressive, it can be quite an impressive infusional reaction. And there's a big cutoff between grade 2 and grade 3. Grade 3 is where patients really can become quite sick and require much more significant support, typically in an ICU-like setting. Whereas for grade 1 and 2, mostly can be managed, most could be managed in an outpatient setting, although we typically admit these patients, at least for a period of time. So as you can see here, the cytokine release syndrome was only seen in one patient of grade 3 level, but obviously this is important. I think we're learning a lot more about CRS, both for CAR T and for bispecifics, and I suspect that these numbers will improve with time, especially with a more aggressive preventative strategy with drugs like tocilizumab and steroids in advance. But I just showed you teclistamab. If I had time and if I wanted to put you all asleep, I could talk to you about elranatamab and the Regeneron product, pavurutinib, which, the artist formerly known as AMG 701, talquetamab, and cevostamab. I mean, we have many of these, and this is also not an exhaustive list, but I just took these from the ASH meeting to give you a flavor of all the different types that we have. Some will target BCMA, some target GPRC5D, some target FCRH5. Some are given sub-Q, some are given IV, although the majority are sub-Q. And in the ballpark area, we have a lot of similarities around response rate, maybe some differences in CRS, but as these studies mature, we'll understand them better. And in a disease, frankly, like myeloma, where we're not curing people, I always want more options, and we're thankful to have options like this. So how do I conclude this whole section on the developments we've seen in late relapse? Really unprecedented response rates. I mean, if you told me even a few years ago that we're going to see over 90% of people respond to CAR T, I would have thought that maybe you weren't so stable, but it's just remarkable what we've seen. We're going to have more options with time. Bispecifics, I mentioned, can allow T cell engagement without collection. And now that, myeloma sadly does become resistant, as we've said, we want to have multiple targets. And it's encouraging to know that we will likely have those with these other targets that I've mentioned. I didn't take time to talk about other molecules like iberdomide and modakafusp and others that are being developed. And what about allo CAR T? What about just getting CAR Ts off the shelf somewhere? Not quite at Costco, but can I just get some CAR Ts and give it to a patient without the whole connection? And then, as I mentioned, other ways of using bispecific therapies, maybe not just engaging T cells, but if we engage natural killer cells, we expect significantly less cytokine release syndrome or CRS. And so that may be one of the directions looking in the future. So if I pivot now for a minute, remember I told you I could talk about developments, disparities, and directions. Let's talk about disparities for a moment. The world, thankfully, is starting to shine a light on the significance of disparities in health for a whole host of reasons, from systemic reasons to individual access reasons to trust and other clear phenomenon that we know. I like to summarize the myeloma call to action with these 7 facts. That although myeloma, sadly, is a disease where most people have a delay between the initiation of their symptoms and their diagnosis. In fact, a recent British paper showed that typically the average patient sees their primary care doctor 3 times with signs and symptoms consistent with myeloma before the diagnosis is made. That time is even longer among African-American patients. On average, African-American patients are 5 years younger. So we think of myeloma as generally being a geriatric condition with average age of diagnosis about 70. It's 65 in African Americans. By the way, it's 64 in Hispanic Americans. So I haven't had time to talk about all the health disparities. I'm going to focus within the African American community, but there are many different types of disparities. Myeloma itself is twice as common. That's one of the reasons why we think it's important to really work within this community, because it is the most common blood cancer in African Americans, because it's, to say, twice the incidence in the white patients. Sadly, African Americans are less likely to receive the 3 classic Ts that have influenced survival in myeloma: triplets, transplants, and trials. In fact, now I talk about the 4 Ts because we have recent studies to show, unfortunately, that African Americans are also less likely to access CAR T cell therapy. So the 4 Ts are, that in of itself is enough for us to say this is not right. And we have to make sure we do something about it. Instead of just evaluating the problem, we have to try and fix the problem. There are some biological differences. Interestingly, African Americans are more likely to have lower risk cytogenetics with things like translocation 1114 and less likely to have high risk disease. So you'd think that their outcomes would be better, right? They're not. And you're listening to someone who's African American myself. And so this hits home for me that the survival outcomes are half of what we see with the white patients. So there's clearly a problem here that goes well beyond biology. And interestingly, in a large VA study, when given, at least theoretically speaking, given equal access, the outcomes of Black patients were better, equal, if not better, than what we saw in white patients. So that kind of gives us the hope and the recognition that we can do something about this. We can have an impact if we're willing to do something about it. So because this is, trying to give you a little high-end research update, just this last ASH, we had 20 abstracts specifically in myeloma dedicated to health disparities. I like to always put these health disparity research studies into 2 buckets. They're the ones that identify or diagnose the problem, those that fix it. Overwhelming always land in the diagnosis problem. That's okay, right? As doctors, we want to diagnose something before we fix it, but there's a point at which you can stop diagnosing and start fixing, but we'll get there. And what does it show? What were the key themes? Their inferior outcomes in African Americans. Delay and inequity in diagnosis in African Americans is a big problem, whether it's identifying their signs and symptoms, because it's being confounded by things like diabetes, whether it's actually getting the screening test done or the initial diagnostic test done with simple serum protein electrophoresis and light chains, or even obtaining a bone marrow. A Black patient is less likely to get a bone marrow test than a white patient to diagnose myeloma. And we need that. That's the tissue is the issue, right? That's how we need for what we need for the diagnosis. Continued studies and understanding the disparities I mentioned, the 3 Ts, triplets, transplants, trials, and now indeed CAR T. And specifically, we look at trials, not just all, if you will, general trials, but most pronounced in the so-called pivotal drug trials, those trials that lead to the drug's approval. African Americans account for about 20% of all myeloma patients. So we have drug X that gets approved. and its pivotal study had 2% African Americans. Is that really reflecting the population that we're going to be treating and that have the disease? That's 1/10 of what it should be. And so these are the kinds of things that we have to address. And so we've created in my role at the International Myeloma Foundation, something called the M-Power Initiative, M standing for myeloma-power, a bit of a play on words, of course, where we're trying to empower patients and communities to change the course of myeloma. We accept the fact that the course of myeloma is not acceptable. The fact that there is delayed diagnosis, the fact that there is reduced access, the fact that there's inferior outcomes. These three things are not acceptable to us. And so we want to find a way to overcome it. So what we've done is really focused in this three major arms of treatment to improve the outcomes of African Americans with myeloma. And I'm not here to give a commercial for the work that I do at the IMF, but I think it's so important that all of us have responsibility. When it comes to issues of health disparities and even just DEI in general, diversity, equity, inclusion, I always say there are three buckets. There's personal, professional, and political. I like to leave the political behind and focus more on the personal and the professional, because it affects you as a person and the very work that we do. So our number one is to engage the community. We want to raise awareness about this disease. We're working with anyone who reaches out within the African American community, medical, non-medical. So, National Medical Association, Black Nurse Association, but also non-medical, fraternities, sororities, churches, barbershops, you name it, any way that we can raise awareness around this disease so people can understand if they have signs and symptoms consistent with it, that they can get help. And we've created, as I'll show you, a resource for them to use to do that. Secondly, we want to educate primary care doctors about the earlier and accurate diagnosis of myeloma. So often we hear from our Black patients, well, for a year I was told that my anemia or my proteinuria or my peripheral neuropathy was just related to my diabetes. Little did they know that myeloma was brewing. And so it's important for us to help make that earlier and accurate diagnosis. And then to work within the hem-onc community, like many of you who are listening today who are involved in this community, that we can teach people more about what is culturally competent care. Am I making sure that I'm providing that to my African-American patients, all my patients, frankly? And what am I doing to facilitate their access? In addition, kind of in light of what I shared with you earlier, we're also doing, in partnership with the Levine Cancer Institute in Charlotte, North Carolina, doing a large MGUS screening. So just to give you a picture of, I just got the update that it's actually now, instead of 200,000 visits to the website, it's closer to 250,000 that we just launched a year ago. So really quite remarkable, with all sorts of resources there. So feel free to go to empower.myeloma.org, or even just go to myeloma.org and go to the diversity page, and you'll see some of these resources, where we've tried to do all sorts of things and provide people opportunities to hear stories from others who have experienced myeloma, to get the resources that they need to help with insurance. I did a Facebook Live. I did an interview with Dougie Fresh, for those of you who are familiar with his music. And then even just myeloma made simple. I just spend, in the world of TikTok, where no one has the ability, hopefully you all have an ability to listen for more than 3 or 4 minutes. You've been listening to me forever, for the last 35 minutes, that we can summarize myeloma in just a few minutes, especially for those who may not be as familiar. The direct initiative, as I mentioned, to the primary care docs, teaching them about what are the signs and symptoms of myeloma, what do we have to look for, how do we distinguish it from things like diabetes, and what tests do we need to do. We find, for example, that many of our Black patients never get a light chain test as part of their diagnostic workup. They need that, right? You're going to miss 20% of myelomas if you only do a serum protein electrophoresis. And so we're trying to help that. And then teach that, as I mentioned, the hem-onc community. Our nurses created best practices for nurses treating patients who are African-American with multiple myeloma. And we're doing the same with now a working group with physicians, so we can know the facts about the myeloma, have the right tools, provide culturally competent care, and even encourage clinical trial participation. Well, before I come to my end, we've talked about developments. We've talked about disparities. Now let's think for a minute about directions. And I could babble on about this for ages, but I've tried to choose the top 10 things that I think we're going to see over the next 5 to 10 years in multiple myeloma. First of all, I think we're going to see immunotherapy as the standard of care. We're going to see this through CAR T-cell therapy, through bispecifics, and the next generation of those two modalities of treatment, I think, are very, very heavily going to influence what we do with myeloma. I think concomitantly, we're going to see a reduced use of the older school chemotherapy that we're still using in many contexts, still has an impact. Whether or not CAR T will fully replace transplant, that's why I have to put the word may here to be safe. I don't want to completely offend my transplant homies, especially because I am one too. But there's a very realistic chance that that may happen. I think we're going to see quadruplets replace triplets, just like we saw doublets go to triplets. We're going to see triplets now going to quadruplets. I think we're going to use much better modern imaging. The days of using skeletal surveys should be over. If you're here and you're still ordering skeletal surveys, don't do it. It's time to stop, because, you know, if it's positive, it tells you that there's disease there, but patients need like 30% destruction of the bone for it to be detected. So I think we're going to be using much more appropriate use of things like low-dose whole body CT, PET scanning, MRI, and maybe even PET MRI with time as that modality continues to be developed. I intimated this early in the discussion, but I think we will develop stopping rules. I think there are some patients who have a biological form of myeloma who do not need to be treated forever. And I think it'll be very good for us, not just for their quantity, but absolutely for their quality of life, based on their own biology, maybe their MRD status, so their high risk versus standard risk status. I hope with time that we're going to be able to look at a patient's B cells and T cells and natural killer cells and be able to say, you know what, you've got a good environment to stay in remission. I can take you off treatment. Or, oh, unfortunately, your environment's not suitable to stop treatment because your immune system can't keep you in check. Those kinds of things may guide the length of therapy. Number 6, I think there's going to come a day where we're not doing serum protein electrophoresis or light chains. Just like where we've abandoned pretty much skeletal surveys with something more modern, we're eventually going to ban the old school serum protein electrophoresis because mass spec does it better. Does it faster? Does it more accurate? You know, I do mass spec in a patient. I can look at the monoclonal protein right down to the Dalton. I can tell you if it's the drug like daratumumab or rituximab versus the original clone. I can see if the clone has changed. All of this with a test that's done in a few minutes, frankly. Maybe a bit more expensive to initially set up the testing, but once it's done, it's much cheaper because it's much less labor intensive than what we do with serum protein electrophoresis. I do think it may not be perfect yet, but I think with time, we're going to be monitoring patients much more with their blood than just their marrow. We may still need that sentinel initial bone marrow test, but I'm hoping to stick less needles in my patients' backsides for marrows in the future. And I think that blood monitoring will be one of the ways of the future. Number 8, I hope it. Maybe it's one of these things that I'm aspiring to, that I'm not going to be the only evangelist for this, but we really need to have a greater emphasis in overcoming disparities in myeloma. I hope even just this talk inspires you to recognize the importance of this and to be involved in whichever way you can. I think we're going to see greater enhanced international collaborations. I've learned so much from our chair and Chief Scientific Officer, Dr. Brian Dury, on the matter of collaborating across the world. I give the example here of what's called the LAMN. We've just created the Latin American Myeloma Network, where we're bringing countries together to really work together, do trials that are going to be better because they're done in multiple places at the same time. I think we need each other, and the world in some ways is becoming a smaller place. And so I think greater collaborations are really going to influence our future. And then for those of you, especially earlier on in your medical career, let me get a little old school on you here and remind us that despite the advancements of these great things like immunotherapies and fancy schmancy drugs and mass spec and PET MRI, there is still value to the old school patient-doctor relationship. This is one of my favorite studies published in JAMA now 5 years ago. It's hard to believe it's been 5 years, where they randomized patients actually to the usual practice of communication, right? If the patient has a question, they call, leave a message, nurse calls them back, versus having an iPad where they can communicate more effectively and quickly with their healthcare team, hoping that that improved their quality of life. Well, it didn't just improve their quality of life, it actually improved their survival. So it's one thing to give, as I say, patients these new fancy drugs. It's another thing to listen. I wrote an editorial last year, 2 ears, 1 mouth, a lesson that my father shared with me the day I got accepted to medical school. He said, Joe, God made you with 2 ears and 1 mouth for a reason. You need to listen more than you speak. Now, granted, he was a urologist. I don't know how much urologists listen when they're down there in the nether regions, but he practiced this, and I try to practice this, and I encourage you to Don't just look at the computer when you're talking to your patients. Look at your patient and make sure you listen to them. It may seem like it's taking more time, but I guarantee you it's time saved because it's going to deliver better care to the patient. So as we look at the future of myeloma, it's amazing, isn't it? All these drugs that we have and how we're going to be introducing more of them earlier and earlier in the disease course. For visual learners, you may want this picture more where we see all these different new agents being added as we go through. But it really is a disease that has vastly changed. I went into myeloma over 20 years ago. I wanted to treat a disease where I could make a difference. The average patient lived 1 to 2 years. Now, the average patient actually, if they're not high risk, lives over a decade. And we hope it to be longer even before long. It's a privilege to be a part of the myeloma community and to be involved with so many of the great things that are happening around this planet in myeloma.